Our speaker today is Dr. Chung. Dr. Cecilia Chung is a professor of medicine at the University of Miami and an investigator at the Miami VA. She's trained in rheumatology, clinical pharmacology, and pharmacoepidemiology. Her academic journey began with medical training in Peru and Canada, and following that, she earned an MPH from Vanderbilt University. Subsequently, she completed internal medicine and rheumatology training through the clinical investigator pathway at Hopkins. Her research primarily investigates variability in drug response utilizing pharmacoepidemiologic and pharmacogenomic techniques, along with big data analytics, including claims data, electronic health records, and biobanks. She's published over 117 papers in peer-reviewed journals, and her contributions to drug safety research have been recognized with the Leon I. Goldberg Early Investigator Award by the American Society of Clinical Pharmacology and the Henry Kunkel Award from the American College of Rheumatology. Her research program is funded by the National Institutes of Health and the VA. In 2023, Dr. Chung joined the University of Miami as Rheumatology Division Chief. Please welcome Dr. Chung.
Thank you very much, Dr. Putumana. And thank you, Dr. Weiss, for the opportunity to present today. And today I'm wearing my hat as an epidemiologist, and I hope that through the next few minutes, we can share some of the concepts that we learn in our disciplinary research in terms of how and when to use direct oral antibiotics. And for this presentation, I do not have any conflicts of interest there. And the objectives of today's lecture are going to be first, to recognize the indications for oral anticoagulation in patients with atrial fibrillation. Second, to identify risk factors and how to prevent gastrointestinal bleeding in patients taking oral anticoagulants. And third, to recognize common drug-drug interactions in patients taking oral anticoagulants. And what we're going to be doing is first, through a case, we're going to give the framework for this presentation. Second, we're going to be introducing some basic concepts of atrial fibrillation, its importance, why we all need to care about it. And third, I'm going to be presenting to you briefly 4 papers that our group contributed recently. So let's start with a case. So for residents, for students, you are in the consult service of cardiology and you are called to render an opinion on a 66-year-old white woman who was admitted with atrial fibrillation. Her past medical history included hypertension, type 2 diabetes, and she also reported recurrent UTIs and a history of chronic gastritis. Her medications included diltiazem, losartan, metformin, and ciprofloxacin. And during your conversation with her, you realize that she's interested in learning about whether she needs to be taking these, what she calls blood thinners, that she heard from her neighbors. So the questions that we're going to try to address during this presentation are, first, whether she needs to use an anticoagulant, and if so, which one? Second, what about risk factors for gastrointestinal bleeding, given the fact that she reports gastritis in the setting of using anticoagulants? And if she is at risk for drug-drug interactions, given the list of medications of drugs that she's currently using. So let's start with why we should all care. Why would a rheumatologist care about atrial fibrillation? Why everybody in internal medicine needs to care about atrial fibrillation? And let's start by saying that this is a very common form of arrhythmia, and it actually affects around 60 million people worldwide. And if that doesn't convince you, we can say that just in the United States, the estimation is that around 3 to 6 million people are affected by atrial fibrillation. But it's not only that, it's also that the incidence keeps rising. So it is estimated by 2050, around 6 to 16 million people in the United States are going to be having atrial fibrillation. But in addition to that, the importance of atrial fibrillation relies that it's not just a cause of symptoms that can be expressed by patients as palpitations or even pre-syncope, but because it's also, among many other things, a common cause of preventable strokes. And for the students in the audience, if we think about how the heart works, under normal circumstances, what we have is a regular rhythm that is expressed here in this EKG, and we can see how the rhythm is normal. In contrast, in patients who have atrial fibrillation, what we're going to have is these erratic impulses. And with a disorganization that is expressed in this EKG here, in which we see how what we see is an irregular rhythm. But again, I mean, this is important because of the symptoms, but also because of the long-term consequences. And outside of cardiology, it's been well established that atrial fibrillation is linked with an increased risk of Alzheimer's. It's also linked with an increased risk of chronic kidney disease. But if we focus on the cardiovascular disease, it's also linked with several cardiovascular outcomes. This is, to my knowledge, the first paper actually recognizing the link between atrial fibrillation and stroke. And this was a pretty clever study published in 1968 in Circulation. So what investigators from the CDC did was that they studied patients who were all part of a community retirement place and for whom they had data prior to the development of stroke. So they were able to enroll 117 patients who had a stroke and who had data prior to that stroke. And they were able to identify also control subjects. So a total of 234 control subjects. And these control subjects were matched to the stroke patients by age, by sex, by duration of follow-up, and also by blood pressure. And somehow expected, they found that patients who had a stroke had a prior history of coronary artery disease in a higher frequency, also of hypertensive heart disease and heart failure. But what was kind of relatively surprising to them was the significant difference of atrial fibrillation preceding the stroke. So for this study, almost 20% of patients who had a stroke had a prior history of atrial fibrillation. And this was in contrast to only 3.4% of atrial fibrillation among the control subjects. So highlighting this important difference, they concluded that at least in their group of patients, 1 in 5 episodes of stroke occurred among patients who had a history of atrial fibrillation. So following this initial report, there have been many other studies actually confirming this association. And here in this recently published review in JAMA, we can see how data from a systematic review reported that at least there was a 2.4-fold increased risk for strokes among those patients who had atrial fibrillation. And we can see how this impacted also what the investigators call as restricted mean time lost in the number of disease-free years, with 6.2 years that were lost by age 95 and projected just by having atrial fibrillation. So highlighting the importance of atrial fibrillation and its consequences in the well-being of patients overall. But not all patients with atrial fibrillation have the same risk for stroke. And there are multiple tools that have been used to try to estimate and to try to stratify this risk of stroke among patients with atrial fibrillation. I think the most commonly used now is the CHA2DS2-VASC score, which it was actually derived from patients from Sweden, and in an exercise in which epidemiologic data was used to try to estimate, the risk of strokes minus the risk of intracranial bleeding in the setting of anticoagulation, trying to estimate when the benefits of anticoagulating patients could, overcome the risk of bleeding. And the investigators put together this series of variables that can be used to calculate the score. And here we see a summary of how the score is calculated. So based on, this is an acronym for C for congestive heart failure, H for hypertension, A for age, which could have 1 or 2 points depending on which age category a patient falls. T for diabetes, S for a history of a stroke or TIA, VASC for vascular disease, which includes a history of MI, but also a history of peripheral artery disease or aortic atherosclerosis. So based on the data that we had in our 66-year-old patient, because she also had a history of hypertension and diabetes, her score would be 4. And this score can be used to try to estimate, the ischemic stroke risk per year. And here we can see how for those patients who have a score between 0 to 1, this unadjusted ischemic stroke rate per year is less than 1%. In contrast, patients who have a score of 2 or more are going to be having an estimated unadjusted ischemic stroke risk rate per year of more than 2. And this is important because experts in cardiology estimate that if your risk is about 2, you probably should be thinking about, the use of an oral anticoagulant to try to prevent strokes. So in our case, for our 66-year-old patient with a score of 4, I think she would fall into the category in which an oral anticoagulant is recommended. But then the question is which one? And for all of us, all enough to be trained in the use of warfarin, this was for many years the treatment to go. And it was based on many sources of data. This review from 2007 in the Annals of Internal Medicine actually summarizes important data from randomized clinical trials for which there was at least a follow-up of 3 months, and it included patients with non-valvular atrial fibrillation. And we could see how, in average, patients who received warfarin had a 64% reduction in the risk of having a stroke. So emphasizing the efficacy of warfarin as a way to prevent strokes in patients who were at risk for stroke and atrial fibrillation. So, but this is the good. What is the bad and what is the ugly in terms of what we think about warfarin? And one of the challenges that treatment with warfarin brought was the need for careful monitoring. And this included dose titration. This included the fact that warfarin has a very narrow therapeutic index, which means that doses that are beneficial, that are efficacious, are usually already linked with side effects. But also because of the numerous drug-drug interactions with many antibiotics, classic antifungals, antidepressants, antiplatelets, anti-inflammatories, and even alternative remedies. And if we want to go outside of the drug-drug interactions, even with food. So the requirement of careful monitoring, the requirement of constant checking of INRs is or was one of the limitations of the use of warfarin. The ugly also came in terms of what it means in terms of the risk of serious bleeding, patients who actually required to be admitted to the hospital, patients who required blood transfusions after episodes of bleeding. And the estimation was that patients who were on continuous treatment with warfarin had a 3 to 8% rate per year of having these severe side effects. So there was clearly a need for medications that would offer at least the same efficacy with less side effects and ideally with less need for monitoring. And that was what subsequent research actually brought. So in the New England Journal of Medicine in 2011, we had two back-to-back large randomized clinical trials looking at two different direct oral anticoagulants. These are medications that actually are factor-activated 10 inhibitors. And this slide actually summarizes the results from one of these randomized clinical trials looking at the medication is rivaroxaban as a medication to try to prevent, for this study, the primary outcome was the composite of risk of stroke or systemic embolism. And the comparator was warfarin, which at that time was the standard of care. So there were around 7,000 patients randomized in each arm. And we can see here the results of the primary outcome. It is important to emphasize that this study was designed as a non-inferiority trial. So we can see here how rivaroxaban actually was definitely non-inferior to warfarin, and for some of the outcomes actually was superior to warfarin in terms of stroke prevention. But what was also interesting was to look, and here is the data on bleeding events and how we can see that for the critical bleeding, bleeding that required transfusion and fatal bleeding, the rates were lower in rivaroxaban compared to warfarin. So this was quite reassuring and indicating that rivaroxaban was a good option for patients who had atrial fibrillation and required anticoagulation. The other study was a study looking at apixaban, another factor activated 10 inhibitor, again compared to warfarin. Similarly to the previous study, it was a study designed as a non-inferiority trial. However, for my understanding is that in this case, for all outcomes, apixaban actually ended even showing superiority to warfarin in terms of prevention of stroke or systemic embolism, here depicted in this figure, with apixaban rates being lower. And the same happened when investigators looked at major bleeding, with apixaban showing lower rates of major bleeding. So these two studies, among subsequent research, were the foundation for these new medications actually becoming a better alternative for patients who require an oral anticoagulation because of atrial fibrillation. But then for our particular patient, the question is, okay, she requires an oral anticoagulant. With the data that we had from the randomized clinical trials, we think that the DOACs seem to be a better alternative than warfarin, but which one should we use? And that was a rationale for a study that we conducted using Medicare data. So in this study, what we did was conduct epidemiologic study comparing outcomes in patients who receive rivaroxaban and apixaban to try to determine if one was preferable to the other. And as you can see, the numbers in epidemiologic studies are pretty large. But before we go into more details of this particular paper, let me just take a few minutes of your time to go over a couple of fundamental concepts that I think are important as we understand this type of studies. The first one is that we can estimate actually drug exposure using different sources like biologic methods, interviews, or databases. And we're going to talk about studies looking at databases because they are more feasible and because they allowed us to study large numbers of patients. And what we do in these studies is that we use records that were collected for other purposes. In this case, if we're using Medicare data, these are Medicare records that were collected for purposes of reimbursement. But putting together data on medications that were picked by patients together with codes that were derived from outpatient or inpatient encounters or procedures. And that put together with demographics, we can reconstruct individual histories in a large number of patients and conduct these studies known as retrospective cohort studies. Many advantages of these studies include that the drug exposure data is unbiased, in contrast to what could happen in an interview, which patients can forget about some exposure to medications, that it's feasible to track changes of medications and new diagnoses over time. And as we said before, that these studies are feasible for very large numbers of patients. But let's think about some challenges that these studies bring. And I think the main and the one that I really want students, residents in the audience to remember is the differences with randomized clinical trials. In a randomized clinical trial depicted here, what we have is the randomization. And by virtue of randomization, patients who are exposed to a drug versus patients who are unexposed or who are getting the standard of care tend to be very similar. So, so the inference of the difference between outcomes is quite valid, I tend to think. What happens in real world data that we use to conduct either cohort or even case control studies is that the exposure is not random. There are reasons why a doctor or in general any provider may prefer to prescribe one drug versus no drug or to prescribe one drug versus another drug. And it is important to take these differences into account because these differences otherwise can drive us to conclusions that may not be accurate. So let's look at this from a different perspective. So we have the exposure here, and we have the outcome. And for example, when we decide to give a PPI in real life, it's going to be different than if we are conducting a randomized clinical trial. It's very likely that we are deciding, for example, to prescribe a PPI is because patients have a higher risk of gastrointestinal events. So if we just count events without taking into account differences that could be present in patients who are getting a drug versus another, could lead us to a distortion in the estimation of a measure of association. So there are ways to account for this. A way that we still sometimes use is the estimation of risk scores. But I want to emphasize a way that was used for us in the 4 studies that we're going to review, and that is commonly used to account for these differences in most contemporary pharmacoepidemiologic studies. And this is the use of propensity scores. What is a propensity score? A propensity score is the probability of a patient getting one drug versus the comparator, given a standard set or given a set of variables. And this is important. Giving a set of variables means that we're going to be able to account for the variables that we are including, but we're not going to be able to account for the variables that we are not including. So every time that you look at a propensity score, please look at which variables were included. And with a propensity score, we can either match, we can stratify, we can use inverse probability weighting techniques, we can use stratification to try to account for these differences that we're going to see. So with that in mind, with understanding that, let's go over the last concept that I think it's important to remember when we look at these pharmacoepidemiologic studies, and it's the concept of why we need to use a user design. Now, people call it user design a trial emulation design. I think the concepts are quite similar, but the idea is that in particular, when we're thinking about, for example, side effects, patients are going to be susceptible, and then we're going to have, over time, a depletion of the susceptibles. So if we don't take new users, if we start enrolling patients who have been using the drug for a while, we may have a distortion in terms of the risk of a side effect attributed to the drug. And it is important, therefore, to try to include new users design, which will allow us to try to mimic a randomized clinical trial as much as possible with the use of these large sources of data. So let's go back to the rivaroxaban and apixaban example with these concepts in mind. And what we did was a retrospective cohort study with a new user design. So meaning patients who have not used any of these study medications in the prior year. So we anchored the follow-up at the time of first use. And for this study, we included Medicare beneficiaries who were 65 years or older, who had atrial fibrillation. We excluded patients who who had multiple comorbidities or who were in nursing homes. And the exposure was either rivaroxaban or apixaban. And the primary outcome was a composite of major ischemic and major hemorrhagic events. With major hemorrhagic events, including an intracranial bleed or a death related to a hemorrhagic event. And this table actually gives us a flavor of how the propensity score is going to work to try to account for potential differences, even if the differences are relatively small, as how they were at baseline for our study. So here we see the unweighted part of the table in which there was a small difference in age, with patients on apixaban being slightly older than patients who were getting rivaroxaban. And we see how after the applying the propensity score weighing techniques, we can see how these differences pretty much go away. And again, this highlights one difference. Actually, we, for this study, included more than 200 variables. And the weighting actually adjusted for differences in all these 200 variables appropriately. And this figure summarizes the main results of our study, in which comparing rivaroxaban with apixaban, the rate of ischemic or hemorrhagic serious events was higher in patients taking rivaroxaban. And this table here on the right actually highlights some of the components of the primary outcome and some secondary outcomes. And we can see how for pretty much almost all of the components, the results were consistent. And I think this adds to the robustness of the results. Here we can see how total mortality was slightly different. But I think, for the primary outcome, the difference was pretty clear. So I think based on this study and some subsequent studies following this one, I think my preference would be for our 66-year-old patient to recommend apixaban over rivaroxaban. But let's switch from which one to talk about the risk of gastrointestinal bleeding and what we can do to try to prevent serious gastrointestinal bleeding events in patients who take oral anticoagulants. And to try to answer this question, we conducted also a retrospective cohort study, again with a new user design. And for this study, we look at Medicare beneficiaries who were getting all sorts of oral anticoagulants. For this particular one, we included warfarin even. And the exposure here was the use of a proton pump inhibitor. And the primary outcome was hospitalizations for upper gastrointestinal.
Un momento tan difícil, tú sabes, con nuestro presidente ahora. Y yo pensaba que todo iba a estar bien aquí, pero mandaron un memo.
Sorry about that. I made sure to mute.
Okay. So here we can see the distribution of patients who were taking a PPI as a co-therapy versus no PPI in the 4 oral anticoagulants that we studied. And what this figure presents is the comparison between the use of PPI co-therapy in blue versus no PPI use in orange, and how the rates for hospitalizations for upper gastrointestinal bleeding was higher regardless of which anticoagulant was used among those patients who were not taking a PPI therapy, so suggesting that overall this was something to consider and a strategy to consider. But in particular in whom? For this study, we estimated gastrointestinal bleeding risk based on 86 covariates. And we stratified patients on different categories based on their overall gastrointestinal bleeding. And we can see how this protection was more remarkable in those patients who had a much higher gastrointestinal risk. So for your high-risk patients, please consider concurrent use of a PPI in those patients who are taking an oral anticoagulant, regardless of which one it is. And from that perspective, let's now switch to what happens in terms of drug-drug interactions, in particular for those drug-drug interactions that are going to be important in those patients who have atrial fibrillation. And when we think about the management of atrial fibrillation in general, cardiologists are going to teach us about how they think about rate control and how they think about rhythm control. And the 2 medications that I want to highlight are diltiazem, that is a medication that can be used for rate control, and amiodarone, that is a medication that can be used for rhythm control. And this is important because given pharmacokinetic and potential drug interactions, these are drugs that raise concern. So, and how is that? What happens is that both apixaban and rivaroxaban are C3A substrates, which means that if C3A4 doesn't work or somehow it's inhibited by another concurrent medication, we're going to have some kind of buildup of the drug, and it's like the equivalent of potentially taking too much of the drug. And this is important because, again, I mean, these medications can be and are actually being prescribed in patients who are taking one of the oral anticoagulants. So a potential drug-drug interaction that could be increasing the risk of a bleed in those patients who are taking an oral anticoagulant. So that was the rationale for the two next studies that I am going to present. So the first one was looking at amiodarone. And this is another retrospective cohort study with a new user design. And for this study, it was important to look at a comparison with an active control. For that active control, the ones that were the closest that we were able to identify were sotalol and flecainide, which actually don't affect CYP3A. And the outcome was hospitalization for bleedings in general. And this table actually summarized the results of the study with the primary outcome and components. Here we can see how with a hazard ratio of 1.44, so there was an increased risk that was significant for bleeding among those patients who were concurrently using amiodarone versus those who were using flecainamide or sotalol. And this was after adjusting for differences at baseline to the best of our ability. And we also wanted to look at whether this risk was different or varied based on the baseline risk for bleeding. And for the risk of bleeding here, what we did was we implemented a score that could be adapted to big data. And this is a score that is called the HAS-BLED. And HAS-BLED comes from hypertension or altered renal or liver disease. S is for stroke. B is for prior major bleeding. L is for labile INR. So please note that this score was developed at the time of warfarin use. E stands for, they call elderly for those who had age of older than 65. And D for medications or alcohol use. So each of these components give you 1 point. And what we did was we stratified this drug-drug interaction based on the HAS-BLED score. And we can see how there was some difference, in particular for those patients who were using rivaroxaban, high risk of bleeding, those who were taking amiodarone versus those who were taking flecainamide. But look at this here. I want you to notice that the magnitude of the difference was more important in those patients who had an overall baseline risk of bleeding that was higher, highlighting the importance of taking into account that baseline risk when we're thinking about potential additional risk with co-administration of other medications. With a similar concept to what happened with amiodarone, we looked at diltiazem, again, calcium channel blocker used for rate control. And using a similar design, in this case, the comparator for diltiazem was metoprolol. And what we looked was, again, at hospitalization and death that was attributed to bleeding. And here we can see how the use of diltiazem was linked with a 21% increased risk of having a serious bleeding compared to the use of metoprolol after adjusting for differences between them. And this was important as we also looked at the different components of the outcomes. So let's go back to our patient, our 66-year-old white woman with atrial fibrillation who had hypertension, type 2 diabetes, recurrent UTIs, and gastritis, and was taking diltiazem, losartan, metformin, and ciprofloxacin. To the question of does she need to use anticoagulants, the answer is yes, based on her overall CHA2DS score. She qualifies for the use of an oral anticoagulant. To the question of which one, we know from randomized clinical trials that DOACs are better than old-fashioned warfarin. And I would say that between the DOACs, the data now favors the use of apixaban. In terms of the gastrointestinal bleeding with anticoagulants, because she's hypertensive, because she's older than 65, and because she's taking diltiazem, she is at a higher risk of having gastrointestinal bleed. In particular, if she's taking higher doses of diltiazem, more than 120 milligrams, I think that the data would favor the use of a concurrent PPI to try to prevent gastrointestinal bleeding. And if she's at risk for drug-drug interactions, the answer would be yes, because she's taking diltiazem. So this is as we think about this particular patient and how data from epidemiologic studies can supplement data of what we learn from randomized clinical trials and help us inform, better how to better treat patients with given conditions. And as we think about this, I want you to think about where we're going next. The inclusion of the white race here was intentional. And the reason is because these scores were primarily developed, the risk score for, to determine if a patient should receive an anticoagulant or not. And the bleeding scores were primarily developed in patients of white race. So I think it is important to be cognizant of that and try to include patients from other races in our research as we think about how we prevent bad outcomes, in particular because patients who are African American are at a higher risk of having strokes. So I think it is important. But it's also important as we think about how we are going to approach the next steps. And I think it is good to know about the role of independent risk factors, such as the use of diltiazem or the use of amiodarone. But I think what a future medicine is going to require from us is how we integrate all this clinical data and how we integrate genomics data. And again, as we think about including patients from different ancestries, it is important to recognize that, for example, the expression of 6385, which is also involved in the disposition of oral anticoagulants, actually varies by ancestries. I think highlighting where I think we need to go as we think about how we're going to be personalizing care in our patients in general. And with that, I want to close and I want to acknowledge my former mentors, members of our team, our multidisciplinary team, and the sources of funding for this research. Thank you very much. And
thank you, Dr. Chung, for that very practical and informative and very clear presentation, very case-based, and showed us the importance and use of big data. If we could take down the slides for a second. Perfect. Thank you. I might begin, we have some time for questions. I might begin by asking, when you, with these large, big data sets, I imagine, and you mentioned the issue of disparities, you would think that things like zip code and other social determinants of health could easily be plugged into the algorithm to help us understand. And if that's the case, is there an app available on my phone that I could plug in all these variables and come up with the ideal drug and dose, or we're obviously not quite there yet?
I don't think we are there yet, Dr. Wines, but you're right. I mean, there are different variables that can be used to adjust for that. So, with zip codes, the CDC has developed some indices that can be applied in as we de-identify data, because I think it's important to de-identify data to conduct the following steps of research with this type of data. And zip codes are considered identifiables, so we can use zip codes using CDC data to try to account for this, at least partially for these social determinants of health.
Well, seeing that there are no other questions, I thank you very much for an excellent grand rounds. And I know you were substituting for a guest visitor, but it was, I'm sure, better than the guest would have been able to do. So we thank you very much and look forward to interacting with you as we see these patients in the future, not just this, but rheumatology as well. I remind everybody to look on the chat for the link for the CME MOC credits, and I look forward to seeing everybody next week. Take good care.